start. You see my slides? Yeah, I assume yes. So yeah, welcome to my presentation with the aforementioned title. And it's definitely surely commonly known that heart failure represents a major health public problem that has been escalating over the last years. There are over 40 million of patients that are affected by this disease worldwide. The overall prevalence of this disease is 2 to 20 cases of 1,000, but it reaches a mark of 100 or more than 100 cases over the 1,000 of population in those who are aged over 75 years. Within the first 5 years of the diagnosis, it results in 60% mortality rate. And in total, it occupies 130% of the total healthcare expenditure in Europe and North America, thus representing a severe socio-economical burden. The heart failure results in insufficient blood pumping, which means that the metabolic body needs are not met, and cardiac resynchronization therapy is used to improve the contractile function of the heart, which is intrinsically coupled to the electrical activation of the heart. The most common mode of CRT treatment is the biventricular pacing, where two stimulation leads are placed on the heart. So the right ventricular electrode is placed endocardially at the RV apex, and the LV lead is positioned epicardially to be on the lateral left ventricular wall. There are also some more recent approaches, CRT approaches, that include, for example, multi-point pacing. The difference there is that the left ventricular catheter has up to four stimulation sites and the same RV pacing electrode. There are also his bundle pacing protocols where his bundle is engaged directly to stimulate his Purkinje network and to treat bundle branch blocks. An optimized or advanced version of that is a so-called his optimized CRT or hot CRT, which includes his bundle pacing combined with either biventricular pacing or LV or RV pacing, depending on the clinical indications. Biventricular pacing is, however, a golden standard nowadays, and it results, however, in only around 70% of efficacy, leaving approximately 1/3 of patients untreated without an acute response. And there are many factors that are associated with this high non-responders rate, including disease etiology and prognosis, patient selection, gender, as well, presence of myocardial infarction or atrial fibrillation, baseline QRS characteristics, and some other clinical parameters. But during the implantation procedure itself, the left ventricular lead technology and the placement of the leads play the most crucial role. While we know that during the biventricular pacing, the RV stimulation electrode is more or less always placed at the RV apex, the position of the LV lead is surely patient-specific. It depends on the venous anatomy because it's epicardial axis. But even when we target the right vein, the right coronary vein, then there is still a question where to put the lead along this vein. And in the first part of my presentation, I'll talk about this problem of optimal placement, optimal LV lead placement to increase response rate for the classical biventricular CRT therapy. We know that there is documented evidence of improving CRT response by placing the LV lead close to the late activation area, but outside of this current tissue. The target investigation demonstrated this clearly, and also performed a feasibility study where the venous geometry was reconstructed using echocardiography. We know that MRI can also provide additional benefits about the scarring information, about the structural information of the heart, but the electrical information still remains silent. There have been suggested other electrical parameters that go beyond the QRS duration that might be or should be actually used for an improved CRT therapy. And within this context, ECGI is a novel modality that can be combined with the existing approaches and can identify the electrically late activation area. Up to date, we can say that the most complete LV guidance protocol include combination of MRI, venography, and ECGI for the lead placement. So in our study, we wanted to investigate performance of such a combined protocol and its influence on the responders rate. So we included 60 CRT patients who had complete left bundle branch block, and they all adhere to the standard clinical CRT inclusion parameters, meaning that they had QRS duration of over 150 milliseconds. The ejection rate was lower than 40%, and they were associated with the stages 2 and 3 of heart failure according to the New York Heart Association. As the standard intra-operational tool for identifying the target vein, we use fluoroscopy, which is a standard clinical procedure for the CRT or during the CRT implantation. In our multimodality approach, however, we also included contrast cardiac CT or venography for vein visualization and identification of target vein. We used also body surface mapping with up to 240 channels to identify the electrically late activation area. And we use also delayed enhancement MRI to identify the fibrosis, to gain the scarring information. We divided our patients into two equal groups after the so during the pre-implantation in both groups, there was a standard clinical examination, which included ECG and echocardiography recordings for the second group, which we call ECGI-based group. We also performed an ECGI to evaluate the late activation zone during the native rhythm, and perform also delayed MRI to recover the information about the fibrosis, and that was done within on the same day with the standards examination, and within the 5 days we also made the cardiac CT or venography to get the anatomically patient-specific exact location of the coronary venous system. For the device implantation in the control group, we were just guided by this normal fluoroscopy, whereas for the second group, we merged the information from all modalities that we had. So we used the fluoroscopy, we used the venography, and to identify the target vein, which was merged with the anatomical patient heart, and placed the lead just outside of the fibrosis, so at the late activation area close to the fibrosis. Only for the validation purposes, we also performed ECGI after 3 months to evaluate the isochronal maps during this patient, and as a part of the standard follow-up, after 6 to 12 months, the patients were again examined, and standard clinical checkups were performed to evaluate whether they responded or not to the chosen treatment. So here on this slide, you see the clinical baseline parameters of these two groups. So those groups were equal, and as you can see, the parameters that can be otherwise decisive for the CRT response were similar, so they were not significantly different from each other between the groups. So that's why we were sure that these groups are equal and we can compare them. Those patients had, however, like the same clinical characteristics in common, that they had a wide KRAS complex. Majority of them had a left bundle branch block, and half of them revealed myocardial infarction. So on this slide, you see actually the main results of this first study that I wanted to share with you today. Response in 1 year after the CRT implantation. We notice immediately a high non-respondent rate of 43% in the control group, where the CRT device placement was done according to the clinical guidelines. And we see a 20% in the responders increase in the ECGI-based ECGI or multimodality approach guided group. Given statistical significance of group similarity, I think we can claim that ECGI can help to increase the CRT response rates. In addition to the success rate calculation, we also investigated on the connection between the response and the distances between the LV pacing electrode and the late activation zone area, and distances between the LV and RV pacing electrodes. That's interesting to observe that for the responders, in the ECGI group, we could clearly separate responders from non-responders based on the distance, based on these two simple metrics. That's pretty logical that responders exhibit shorter distance between the late activation zone and the LV pacing pole, and that was our intention. But they also exhibited larger distance between the LV and RV pacing pole. So it's intuitive, and it confirms also the observations from the previous studies. As a part of the results, I also would like to show you some isochronal maps. Here you can see an example of response. On the top, you see that the chronal maps in the native region before the CRT implantation, and then the LV lead was placed in the middle of the late activation area, and the synchronous bi-V pacing, LV-RV pacing, resulted in a synchronous fusion beats, and this patient responded acutely. The distance between the LV-RV electrodes was, in this case, 117 millimeters, which is quite wide apart. And an example of the non-response. So here you can see that the LV lead was placed very far from the late activation area, unfortunately for this patient, and the distance between the poles consisted only 50 millimeters. In the first group, we also analyzed the activation maps and evaluated ECGI for predicting the response. So from this REC curve analysis on the left, you see that the area under the curve for ECGI to be a predictive tool is 0.87. Furthermore, we made a linear discriminant analysis model, which was based on the interelectrodal distances and the LV LAZ distances. The three positively predicted patient that did not respond, on the right hand side that you can see them, they are being investigated on. So overall, this study demonstrated that ECGI could predict response before and during CRT implantation with 95% sensitivity and 85% specificity values. And the second part of my talk, I would like to talk about the role of the ECGI for device optimization after after the CRT was already implanted. I would like to present you results of our collaborative work with Professor Budi from University Clinic of Geneva. For this prospective study, 19 patients were enrolled and many pacing configurations were performed. So you see that 32 patients in this pacing protocols on average with a 12 standard deviation were performed. So they included intrinsic rhythm, the His bundle pacing, the hot CRT, which means that the His bundle was stimulated, and then biventricular pacing or alveolar airway pacing were added depending on the clinical characteristics. The pacing delays were 10, 0, 20, 30, 40, 60, and 80 milliseconds between the His bundle pacing and the additional pacing. Then biventricular standard classical biventricular pacing was also performed, which included the quadripolar alveolate as it's used for the MPP, plus the standard RV pacing, then MPP itself with different delays between the left ventricle and right ventricle stimulation, and just single RV and LV patients were also analyzed. This study to evaluate the performance of different pacing configurations, we used ECGI-based lowest left ventricle activation times, and in case of right ventricular bundle branch block, right ventricle activation times, and the electrical delay, longest ventricular delay for the to evaluate the performance of the biventricular patient to assess the best pacing mode in the standard BIV. Here you see the results of the study, and we see that the hot CRT, so the probably the youngest approach resulted in 21 and 25% of LVAT reduction compared to the His bundle pacing alone and biventricular pacing respectively. For the whole cohort, LVAT did not significantly differ between the intrinsic rhythm and the His bundle pacing. The hot CRT optimized setting for maximum reduction of LVAT was His bundle plus BIV pacing in 2 patients, then combined with the LV pacing in 11 patients, and combined with RV pacing in 6 patients. Among them, 5 had right ventricular bundle branch block, so that's logical. So they better responded to the addition of right ventricular pacing to the protocol. To estimate the robustness of ECGI estimate, each patient or each configuration, each patient underwent the same pacing protocol twice that was randomly assigned during the clinical evaluation. Here you see the results of the azichronal maps for the optimized pacing modes for one patient. So from the His bundle pacing and from the hot CRT, where the His bundle pacing was combined with the LV stimulation, you see that the location of the earliest activation zone is a little bit shifted compared to the His pacing electrode. But for the hot CRT, the early activation area is well captured for the LV4 electrode. And for the biventricular electrode, we also see a distinct early activation at the right ventricular apex and the early activation area, which is very close to the left ventricular stimulation protocols of stimulation electrodes. So in general, we could see that we could see some spatial mismatch between the azichronal maps and the stimulation leads. This study has a prospective nature, so we will see how it impacts the overall conclusions of this study. So we believe that the global parameters that can still be very well captured with the ECGI. So to summarize the presented results, what we've found out is that the combined approach, where we used ECGI plus MRI and mammography, could improve the response rate by 20% compared to the control group. And with respect to the CRT device optimization, ECGI suggested superior performance of hot CRT over the standard classical biventricular pacing and MPP in terms of ventricular electrical desynchrony, where the global electrical metrics such as left ventricle activation, right ventricle activation times were derived from the ECGI recordings. We know that ECGI has some intrinsic limitations during the ill-posedness of the problem, but the impact, as I said before, the impact of some minor spatial mismatches on the global predictive power and optimization ability to optimize the CRT device should be evaluated in the follow-up studies. Thank you for your attention.
Thank you, Daniela, for your excellent presentation. I have a question from Roger Eberkerley for you, which reads as follows. Hi, Daniela. Great talk. Why didn't you do ECGI and other measurements in the control group in the pre-phase? Normally, one tries to keep everything as equal as possible to prevent any possibility of induced bias from the study protocol between control and intervention group. Isn't there any risk for that in your study?
So that's actually exactly the difference between the two groups. So we split them in such a way that the first group, the control group, did not undergo the ECGI, did not undergo delayed enhancement MRI, did not undergo the cardiac CT. So all these extra modalities were performed only in the second group to combine, to show the benefits of this combined approach. So the standard, the control group, the first group, underwent only standard clinical examination, including the analysis of of KRS parameters and of echocardiography recordings. So therefore, we did not do ECGI on that. We did ECGI on both groups only after the implantation, 3 months after the implantation, to evaluate the isochronal maps in both groups and see the differences between these groups in terms of response and non-response.
Any further questions? Thank you, Daniela. Well, if there are no more questions, let me introduce our second.
No. Then we have to switch this one off, Swav. Then we have to go to the other session.
Oh.
Yeah. And you have to wait a little bit because Wojciech is coming in now. Very nice talk. Congratulations on the post-implant data. Question about the non-responders in the first part was 43% non-responders among LBBB, which is high. Why so high? Did you verify clinical events and echo response too?
So 40% is a little bit higher than normally claimed response of 30%, but I think that it's still in the range of normality because this 30% non-responders rate can vary from study to study. So sometimes it can be 20, sometimes it can be 40, as in our case. So did you verify clinical events and echo responders? So actually, the responders, non-responders selection was based on the echo parameters, on the standard clinical guidelines.
In that respect, because I thought that with the ECGI group, the follow-up period was 3 months, whereas in the standard group it was
the standard. So we did only the ECGI after 3 months, but the standard clinical follow-up was done after 1 year. So all the clinical parameters in both groups, in group 1 and group 2, were evaluated after 1 year.
Okay, so that was not completely clear to me. Okay, thanks. Any other questions? for Daniela? Then I think we can end this session and we see you in 4 minutes in the next session.
Thank you for your attention.
Thank you.